Hello, everyone. Thank you so much for joining us. We carry on with the allergy week now on day 2. I won't take up a lot of your time because obviously we're doing this morning sessions as a lightning learning for a quick 15-minute session. Just to say that we are very lucky to have Dr. Maeve Kelleher today to talk to us about FPIES. We touched a little bit on FPIES yesterday, food, protein, and enterocolitis. Look, I can't remember. We always just refer to it as FPIES. And I'm sure Maeve will tell us more about it. Maeve is a consultant allergist working at St. Mary's and does a lot of research and has written a few papers, which I'm sure we can all look up and read up on. Thank you so much, Maeve, for talking to us this morning.
No problem. Thanks, Anne. Great. Hi, everyone. So this lightning learning, hopefully it'll be nice and quick. So as Anne said, my name is Maeve and I'm an allergist in St. Mary's. So the topic today is FPIES. Right, so we'll get straight in. Sorry now. It's difficult, isn't it? Sorry, Anne, just for going down to the next slide in, it should just be.
Don't worry, Maeve, there's always a little bit of lag.
Okay, okay.
Let me know if I can help.
Oh, perfect. Here it comes. Sorry, everybody. Great. So, the overview of today, we're going to look at what is FPIES, how does it present, what type of foods, what's the mechanism, when might you think of FPIES and how is it diagnosed, how do we treat FPIES acutely, be that at home or in the ED setting, and then what's the prognosis. Now, sorry, my seems like the lag is a little slow to get on to the next slide. Oh, great. Now, sorry, this is like slow motion. Grand. So, what is FPIES? FPIES is food protein induced enterocolitis, and it is, even for allergy doctors, it's not something we come across very often. It's not well known, but it's not rare. It's about 15.4 in 100,000 cases per child per year. So it's a non-IgE mediated food allergy, and it's delayed. Typically affects younger children when their foods have been introduced, and it can be life-threatening, though very rarely. And symptoms usually occur 1 to 4 hours after ingestion. So the signs and symptoms are repetitive projectile vomiting, might be lethargy, pallor, diarrhea, dehydration, hypotension, shock, sometimes blood in stools, methemoglobinemia. So you can see all of these are GI symptoms and there's no skin or respiratory symptoms with it. So the mechanism is that it's non-IgE mediated. So it's rather than a Th2 cell reaction caused by an antigen seeing IgE in the system. It's an innate immune system activation using monocytes, neutrophils, and eosinophils, and it's typically a Th1 response. It causes intense gut inflammation and increased gut permeability. You get fluid shift, you get that third spacing, you get diarrhea and lethargy and shock. There's also some neuroimmune mechanisms causing increased lethargy, again, without hypertension or significant fluid loss. So in this slide, you can see, if I get my pointer, so the top is like an IgE-mediated food allergy, where it's your Th2 cells and releasing mediators from the mast cells, whereas in FPIES, it's all gastrointestinal events that are happening. So the diagnosis is typically by a typical clinical picture. Your specific IgE, which could be either a blood test or a skin prick test, are expected to be negative and aren't very helpful. So the diagnosis then is like a clinical diagnosis. So there are a range of different clinical diagnostic criteria, one for like the UK, one for Australia, and one for the US. And they typically have the same thing. What you're looking at is a major criteria, which is vomiting within the first 1 to 4 hour period after ingestion. Of a suspected food. Obviously, you don't know what the suspected food is on the first time it happens. And then some minor criteria are, a second episode of vomiting, extreme lethargy, pallor, needing to go to the emergency department, IV fluids, etc. So if unclear diagnosis, you're not sure, you might suggest a hospital-based challenge to that food again. So then just looking at some other criteria, basically it's pretty the same. The major is repetitive vomiting, kind of 1 to 4 hours after eating a suspect food. And then again, a North American version is the similar. They're saying within 6 hours with the absence of cutaneous and respiratory symptoms. Removing the food resolves the symptoms, and re-exposure elicits the symptoms again. Though depending on how severe the first episode is, that re-exposure may be done in a hospital setting. Oh, sorry. Great. So then what is the role of IgE testing? So IgE testing doesn't explain the reaction of the disease, and it's not typically done. Though about 10% of children with with a FPIES may have a positive IgE to the food. It's not unclear exactly what the relevance is, and really it may be used for if someone also has a positive test, you may slow down the rate of introduction if you were to do a challenge. So in general, we test expecting a negative result. And then sometimes just before a follow-up challenge, if they haven't had it for a while, we would test, and particularly with milk, just prior to challenging. And that would be probably with a skin test. Grand. So the really important thing with FPIES is thinking about a differential diagnosis. So it comes in with acute vomiting and diarrhea. FPIES isn't something that you should be thinking of as the first, the first differential diagnosis, the primary. So really you have to think about everything else first. And in a way, FPIES is often like a diagnosis of exclusion, and it happens after, probably 2 or 3 or sometimes even more events. So obviously the other thing you're thinking about in a young child who comes in with acute lethargy and vomiting, you're thinking of sepsis, gastroenteritis, not so much neck, but and our inborn errors of metabolism would be the ones I'd look at first in smaller children with acute or an obstructive problem. So that would be in smaller children with acute onset of vomiting and lethargy. Rather than FPIES first, but it is important to keep it in your differential diagnosis, and usually it would happen after a couple of presentations. Now, so a typical presentation would be like a 7-month infant exclusively breastfed, starts weaning from 6 months. They've egg for the first time for their tea, ate a few spoons, wasn't very keen, but not all kids are keen on egg at the start, have no immediate reaction. They go to bed. A few hours later, the parents hear a noise in the cot. They go in, the child is vomiting, is after vomiting, has had diarrhea and is really lethargic. They rush in or go to ED. They're treated as acute gastroenteritis, resuscitated with fluids, and home the next day. And it's often maybe on a second or third presentation, a relationship with the food is considered. So the culprit foods, again, they vary actually from place to place. And these are ones that, well, obviously milk is obviously a culprit food for IgE-mediated allergy also, but the foods are different to the foods that you'd see in IgE disease. So looking at across different countries, in the US, it's often milk and soya. Australia, it's rice and milk. Spain and Italy, it's often fish. typically it can be virtually any food. Things like sweet potatoes or chicken are very commonly foods that are culprits in FPIES. About 5% can react through breast milk, and it's about 50% react on first exposure. So it may be that the child tolerated once, and on the second time they have the result. And like I said, relatively, it's often non-suspicious foods like rice, oats, fruit, veg, and meat. So again, this is just looking at a characteristic of 230 children in Australia, and again looking most commonly rice, oats, milk, then things like fruits, vegetables, soya, fish can all cause the same issues. So would you have, is it like food allergy? Immediate food allergy, do you have food FPIES to one or to multiple foods? And again, this will vary across different countries, but the majority of FPIES is to a single food. So say about 30% have multiple food, but 70% have just a single food. You're more likely to have multiple foods if you're younger age. If you have veg or fruit, it often goes together. And then say if it's fish, it usually will involve a lot of fish species rather than one type of fish. So you would avoid all fish then. So there are action plans that you can look at for children who have FPIES to give them this. And actually the BSACI are currently in the middle of coming up with their own one. And the action plans for FPIES, this is the Australian one. And again, it's just showing you that adrenaline and autoinjectors don't play a role, and that it's fluid and ondansetron that you're trying to get into them. So acutely, the acute treatment would be fluids, which would be 10 to 20 mils per normal saline. You could try orally first if it's only mild, and it's ondansetron, be that IV or sublingual again if mild. There's no real evidence for steroids, though occasionally, like I suppose we've seen steroids can be used in a lot of cases as a last resort. And then very rarely an FPIES reaction would involve needing inotropic support and ICU care. Antihistamines and IM adrenaline have no role in it. And the next step would be to strict avoidance. Probably not as strict as someone who is, allergic to nuts and needing to avoid or may contain nibbles or has an IgE-mediated allergy, but strict food avoidance. And then considering introducing like related food under supervision. So FPIES usually resolves, particularly milk and soya. And the resolution rates, like the data is poor actually in the UK. It's more, there's better data coming from Spain and the US. So it really varies across countries and series. IgE tests don't really help you tell if they're going to resolve or not. And actually, really, the criteria is that it's been at least 18 months after your last reaction. So about 50% will resolve by the age of 3 to 4. So then again, as you can see, it's just different cohorts of patients that have been studied with FPIES. The resolution is quicker. Now, so food challenge for FPIES. When might you decide to challenge them in hospital? I suppose it's when resolution is expected. So if a child has had, what clinically sounds like typical FPIES a few times, you don't need to challenge them for that. You need to avoid the food, obviously with dietetic support if it's a big food like milk. And then the food, when you might decide to challenge them to see if they've outgrown their FPIES will depend on the food. Obviously, if it's a big food or if it's a minor food, I mean, if it's a sweet potato challenge, I mean, that can really take its time, particularly these days when outpatient procedures are so limited. You think about the age, the resolution rates in the literature, and the time since last reaction. This is potentially IgE, is that about 10% may have a positive IgE test, and obviously you'd want to see that going down before you would do a challenge. So it's in hospital. Depending on the severity of the last reaction, it may need IV access first, which normally doesn't happen in our acute challenges. I suppose you need observation for at least 4 hours, and typically it's like 8 hours after the challenge. There's very poor data on what doses and what thresholds are given, but in general, it's maybe about 10%, then 2 hours later, about 30%, another 2 hours later, 70% of a dose. About 50%, however, can react at the reintroduction at home. So it is, I suppose can be difficult for families. So introducing of unrelated foods Unrelated foods in FPIES could be done based on your clinical judgment or family preference. It can depend on, one, the severity of the initial reaction, and two is how anxious parents are about introducing other foods. But like, as we said, 70% of children, it's only one food that they are have FPIES to. So it's about kind of balancing the family preferences and the availability of resources in your department. In general, it's done in hospital and a one-day procedure. Now, I suppose the reason to bring this up as part of an allergy week is that there is limited awareness of FPIES outside of the allergy speciality, which I suppose leads to delay and inappropriate advice. Often there's multiple reactions before diagnosis, but like I said, in a young baby with acute vomiting, it's not going to be your first differential. I suppose inappropriately interpreting the test. So you can most children, the vast majority of children with FPIES will have negative allergy testing, but they should not be encouraged to try it again at home. I suppose then it'll allow, if they're not, if it's not diagnosed clearly, parents are then scared to progress at weaning, which leads to unnecessary restrictions, and they don't develop their skills if they're continue on breast milk or on bottled milk. So obviously there can be unsafe home reintroductions if we're not clear about the diagnosis, and it can impact on patients and family quality of life. So the take-home messages are when to suspect. So in children, saying less than 5 years, but typically younger in first presentation, if you get recurrent acute gut symptoms, usually to atypical foods, and if your usual allergy meds aren't working. The acute treatment is fluids and ondansetron, and is not antihistamine and adrenaline. And the resolution, usually by the age of 4 to 5, however, there's no good UK data. Okay, so these are the references that will be up on the channel as well. And then thank you. And these are just a thank you to Dr. Martha Vasquez Ortiz, whose slides here, because unfortunately she was sick today. But if you did want to learn more about allergy, here is some information about the allergy courses that are run in Imperial. Now, so it's just over 15 minutes, but if anyone had any questions, just ask or put them in the chat. And apologies that my pointer wasn't working very well. It took a while for the slides to go across. Oh, hi, Satish. Yeah, so if 10% have IgE atypical, would you recommend specific IgEs? Yeah, I think at diagnosis we would, and it's just to, I suppose, if you have it there at the start, it's a good baseline for when you're reintroducing foods again, and it also helps, I think, both the parents and the carers to understand that, say, if you had a negative test, you're like, look, it's not going to be an anaphylaxis, that this is a different type of allergy, and that we're looking out for signs of vomiting and lethargy and diarrhea. So I think it does help, I suppose, both caregivers and doctors who aren't allergists to understand about it as well. Great. Any other questions?
Amazing. Thank you so much, Maeve. We'll probably wait another minute or so to see if there's any burning
of course. No problem.
question. Anyone? That was perfect. And thank you for raising awareness.
No problem.
I do find that I have to talk about FPIES and listen to talks about FPIES over and over again to ensure that it's not too far at the back of my mind.
Exactly. And I mean, you don't want it at the very top, because like I said, it's more likely going to be sepsis or gastroenteritis. But like, I remember as a reg on call, I definitely picked up a child who came in, and it was their, typical kind of 8 or 9 months, third presentation, and we realized it was FPIES. So I suppose once you realize it, I suppose one is that, the first thing is they instigate management to avoid that food, because parents may not have put the link together first. But it also just saves them kind of unnecessary testing. Do children with milk FPIES required? That's a good point. So in general, we would, it kind of depends on the presentation initially. So if it was quite severe and they ended up in hospital and needing IV fluids, we would just go straight to a amino acid formula. Or if it was milder, we would say go with extensively hydrolyzed. So it does depend, I suppose, like IgE-mediated allergy, it'll depend on the severity of the reaction at the start. I think the other thing is, parents have had a very difficult journey getting to the diagnosis. You might just go straight onto the amino acid formula because they'll definitely tolerate that, whereas there is a small amount, a small proportion who may react again to extensively hydrolyzed. Can FPIES happen while the baby is exclusively breastfed? So yes, there's about of those who have FPIES, which like I was saying is quite uncommon, around 5% may react through the breast milk. So I think it's something to think about, but not particularly common. And then, is there a link between FPIES and celiac disease? That's a really good point. We don't see them go on to have celiac disease more often than those who haven't had FPIES. But I suppose there is, I suppose with allergy and, I suppose an autoimmune disease like celiac disease, there is somewhat of an overlap in presentations at times. I think perhaps not so much with FPIES, but definitely we would see children who have, non-IgE mediated gut allergy. Sometimes that can look at like non-IgE mediated gut allergy, and it is celiac disease. So we'd often, if it's to wheat, we would always do a celiac screen once to rule it out. And then sometimes some of our children who've had chronic gut problems for many years do turn out in their teenager life to to be diagnosed with inflammatory bowel disease, even though their results along the way did not suggest that. Okay. So question, great. So grow out of milk FPIES? Yes. So they do grow out of milk FPIES. Like I said, the data is a bit varied from different countries depending on what cohort you look at. So like the Israeli cohort, 85% had grown out by 3 years. We certainly would say it's a bit later in the UK cohort, but we would expect them to grow out of it by about 4 or 5. So the reintroduction, if they have FPIES, we would have a reintroduction in hospital. So a hospital challenge. They're usually a bit longer than our usual challenges because FPIES is a delayed reaction. So you don't want to finish your challenge at 5 o'clock and send the child home. We want to get the challenges done early in the morning, so we have a long period where we can observe the child afterwards. The confirmatory diagnosis of FPIES is actually, it's usually clinical history. We would do a challenge if it was something that you were not sure about, if the diagnosis was questionable. But often, I must say, the diagnosis is, it's clinical and it's obvious. And unless it's a food that's really important, like cow's milk, like, if you were pretty sure it was an egg FPIES, but you weren't 100% sure, you'd have to do the risk and benefit of having a challenge. And actually, potentially that child could just avoid egg for a year or two and then consider doing a challenge then. So Heba, just your question about, so protein exclusion from mum's food is needed for management. Potentially. Now there is, I must say, even in allergy field, there is debate about how much protein of any foods get into the breast milk. I certainly think there is some. So if it was quite, if it was quite obvious that it was after mum ate eggs, a couple of hours later the baby had reaction. And again, this is like far less likely than the child eating it themselves. You would consider a dietary exclusion then. But obviously, if it's a big food, you want to make sure that that's done, that the mum has some dietitian advice, because we don't want mum to be losing nutrients, because the baby will lose nutrients also. So yes, it can sometimes be protein exclusion from breast milk, but that is definitely very rare compared to the infants who react when they're eating the food themselves. Okay. Thanks, Heba. You're quite interested in allergy, it seems, which is great. So role of pre and probiotics in improving this condition. They're not that I know of. I must say I don't have any evidence that, and when we don't have evidence, I'm not sure that it's been done, but I don't think probiotics play a role in FPIES. No. Okay, so thanks for that. So does any last questions before we sign off and everybody gets back to work?
I also wonder maybe if you have a you have a Twitter handle. Not that I'm on Twitter, but might be worth putting that on the chat
Oh
box.
yeah, I do.
And
I'm
if
starting to
people
tweet a bit more. Yes, you can send it to me there. Excellent. I know. No, I am. I started, particularly at our last conference, I did try to tweet a bit more. So yeah, do. There we go. You can send in any more
Amazing.
questions.
Thank you so much.
No
Thank
problem.
you, Maeve.
You're welcome. Thanks, Anne.
Sorry to have to close it down, but I do think that we should try and stick to the lightning learning. But that was
Perfect.
exceptionally interesting, and I've learned so much as always. I enjoy doing these weeks because you just keep learning, and because they're videoed, you can go back to it and pick up on the
And they're
finer
nice and
details.
quick.
Amazing. Thank you so much,
Perfect.
Maeve.
Bye,
Thank
everyone.
you.
Thank you. You're welcome. Bye.
Bye.